Hi, my name is Melanie Maura and I'm going to talk about Pheochromocytoma and pparaganglioma. Definition: Pheochromocytoma is a rare tumor of adrenal gland tissue. It results in the release of too much epinephrine and norepinephrine hormones that control heart rate, metabolism, and blood pressure. Paraganglioma is a rare type of tumor that arises from the parts of the body nervous system that control blood pressure. Paraganglioma occur in the head, neck, chest, or abdomen.
My name is Paul Landry Aronson. I'm an MD at the Yale School of Medicine in the Departments of Pediatrics and Emergency Medicine. This topic will be pheochromocytoma. Pheochromocytoma is a catecholamine-producing neuroendocrine tumor that most commonly arises from the chromaffin cells of the adrenal medulla. The rule of tens is a helpful rule for the percentages that are associated with pheochromocytoma. 10% are familial, 10% are bilateral, 10% are malignant, 10% are extra-adrenal, and 10% occur in children. Pheochromocytoma is associated with the following conditions: multiple endocrine neoplasia, types 2A and 2B, neurofibromatosis, and von Hippel-Lindau syndrome. Pheochromocytoma presents with episodic symptoms that can be categorized with the mnemonic the 6 Ps: pain or headache, pallor, palpitations or tachycardia, panic or feelings of anxiety, perspiration or diaphoresis, or pressure, i.e. hypertension. Diagnosis of pheochromocytoma is made through elevated plasma-free metanephrines, which is the test of choice for diagnosis. Diagnosis is also made with elevated 24-hour urine metanephrines and vanillyl mandelic acid, or VMA. With discovery of elevation of these blood and urine tests, imaging is performed for tumor localization. It may include CT scan, MRI, or MIBG scan, which is a nuclear medicine scan for tumor localization. Critically, biopsy of a suspected pheochromocytoma should not be performed, as this may precipitate a hypertensive crisis. For treatment of pheochromocytoma, an alpha-adrenergic blockade is given preoperatively, often with phenoxybenzamine. This is to reduce the associated severe hypertension. It is important to not give a beta blocker without first giving an alpha blocker, as giving a beta blocker first will result in unopposed alpha agonism in severe hypertensive crisis. Definitive treatment of pheochromocytoma is surgical resection, often an adrenalectomy.
Application in medicine. The symptoms of pheochromocytoma are headache, heavy sweating for no known reason, strong and irregular heartbeat, being shaky, and being extremely pale. The signs and symptoms may occur at any time or be brought on by certain events like physical activity, childbirth, anesthesia, etc.
I'm talking right now with Dr. Jacques Lenders, who is the Task Force Chair of Pheochromocytoma, Paraganglioma, Endocrine Society Clinical Practice Guidelines. Thank you so much for being here. So I know you have been working really for years on these new guidelines. Can you tell me a little bit about them?
Yes, well, there are several reasons why we felt the guideline might be usable for endocrinologists, physicians in general. And that the first one is that pheochromocytoma paraganglioma is very rare, a very rare disease with a variable clinical presentation, and I would say a doctor has, well, it will be very difficult for a physician to get experience with it because it's so rare. And I think even in larger medical centers, the frequency that the doctors see this tumor is also very rare. So the experience is, for a single physician, limited. That's one reason. The second reason is that if you miss the tumor, if it's not diagnosed and treated properly, it's associated with a considerable risk of cardiovascular morbidity and mortality. And that leads to doctors perform many tests to rule out the tumor. And so I think that's the second reason why a guideline might help to, let's say, to establish the most effective test to rule out or confirm the tumor.
Really, the ability to spare patients having to undergo unnecessary tests.
Well, that's one of the reasons why we felt it might be good to have such a guideline. I agree.
But also in helping to educate the clinicians who, as you mentioned, might not have the opportunity to see this.
I would say the most important step to improve the outcome and the prognosis of patients and also the relatives, that's early recognition of signs and symptoms, so early considering the tumor. And because you can have the best test on the world, but if you do not consider the tumor, then you will miss the diagnosis. So that's another issue that will be reiterated by this guideline. Know the signs and symptoms and consider the tumor in an early stage.
And that, I think, is so critical for people, because you mentioned this is rare, yet having that ability and that knowledge is going to change the field in terms of being able to recognize it.
Yes, that's right. So, but there are some other issues here. In recent years there are new exciting developments, especially in the genetic and imaging field. And we thought that if we have the best available evidence, this could help the physicians to select the most effective test to find the tumor by imaging, or to determine if the patient has an underlying germline mutation for development of the tumor. So that's another issue. It's still an area of some controversy, but and for the time being, I think this guideline can be of help to help the physician. Can be of help for the physicians.
Pros and cons. Pros. Excessive adrenaline or noradrenaline can be found in urine and blood tests. It's possible to live for many years beyond their original diagnosis. Genetic testing may prevent the growth of tumors. Cons. To find the tumors, CT or MRI must be used. It could be inherited by different factors, and symptoms may be misleading.
This is a great case for several reasons, and we'll discover those reasons as we go along. First of all, I think you can see that once again we are dealing with an adrenal gland. Please notice that the cortex is very, very nice, with a nice capsule and kind of glomeruloid little structures underneath the capsule, then little streaming fascicles underneath that, which is the majority of the cortex, and then kind of a reticulated pattern again towards the deeper layer. But in contrast, usually the cortex is really the greatest thickness and weight of the adrenal gland. In this case, it looks like the medulla is tremendously enlarged, and the opposite is true, represents the majority of the gland. This is the classic tumor of the adrenal medulla, called a pheochromocytoma. It is a beautiful tumor for many reasons. One reason is it's one of the rare causes of
Issue applied in Ecuador. There are around 28 key cases of cancer reported in Ecuador each year. In Quito, there were reported 28 cases of paraganglioma in 2016. In Guayaquil, a case of pheochromocytoma was reported and successfully treated last year.
Now, multiple MR images here demonstrate a large mass in the left upper quadrant. Now notice that this mass isn't arising from the adrenal gland. It's probably just arising from the retroperitoneum. You can see that it's T1 hypointense, T2 bright, and demonstrates avid enhancement. Now, if it was coming from the adrenal gland, I would say that it was probably a pheochromocytoma, but this isn't coming from the adrenal. This is an extraadrenal pheo or a paraganglioma.
In conclusion, there are uncommon and complex pathologies. The surgical resolution is mandatory in benign cases, with multidisciplinary pre-surgical preparation to decrease the maximum morbidity and mortality, and with long-term follow-up in all cases.
Hello, Karina.
Hi.
Today, I want to show you just a couple interesting benign tumors that we are treating. So this one is, it's called a paraganglioma, which is a benign tumor that occurs around blood vessels. And so this particular type of tumor is occurring around the carotid and jugular veins in the right side of this person's neck. It's a very large tumor. As you can see in the colored area, it's large enough that it's actually pushing the throat, as you can see right over here, off over to the contralateral side as we kind of scroll through it. And so treatment for something like this is basically either surgery, occasionally it can be embolized, where you basically clot off the blood vessels, or in this particular case, radiation treatment. And so radiation would be the least invasive option, and it has an incredibly high success rate of being able to stop the further growth of these. In some cases it'll decrease the size, but it certainly will decrease the growth to hopefully zero. So what we're doing here is we're treating this using a technique. I'll let you explain, Karina.
So again, as you look at the view here, this is the actual machine, and when it spins around, it's showing you the actual patient rotating around and the beam shooting through these little MLCs,
which are the multi-leaf collimator blocks, so that the radiation will traverse through the center of those blocks. And as the machine is rotating around the patient, it's delivering a three-dimensional volume of dose to cover that tumor very, very nicely, very conformally. And basically these treatments just take a few minutes, and this is about a 5-week course of treatment, I believe, that we're doing for this.
Yep.
Yeah, a little more than that.
A little bit.
Yeah. 6 weeks. And in any case, this patient will have a very good success rate. Thank you very much.
Mm-hmm.
Thank you